Thank you, Mr. Chairman. Thank you, my dear professors and the colleagues, for giving me the chance to present my case today in front of you. My case is titled, Never Lose Your Hope During Cardiac Arrest. This case happened in Aswan Heart Center, Egypt, 2 years ago. Our patient today is 40-year-old male patient. He's a smoker. He was referred from primary BCI non-capable center by acute onset of chest pain of 3 hours duration. He was diagnosed as an anterior STEMI, as you see, by ST segment elevation in the pericardial leads. On reaching the Aswan Heart Center door, the patient arrested suddenly. Code Blue team was notified and CVR was started immediately. Upon attaching the DC device to the patient, it revealed that the patient had VF and he received 200 joule DC shock biphasic, followed immediately by resuming CBR. While we are preparing the cath lab, he received 2 DC shocks and resuscitation was done according to the guidelines without regaining of spontaneous circulation, so the decision at that time was to go immediately to the cath lab while doing CBR. Firstly, we went for the femoral approach, and the femoral pulsation could be felt by the chest compression generated by the chest compression and by anatomical location. We went for XP to cannulate the left main according to the ECG diagnosis. And we will notice that most of the angiographic views in this study will be in the BA cranial view, which was the most suitable angiographic view for both the rescuers and the operator. While the primary operator was doing the primary BCI, the intensivist and the anesthetist were managing the metabolic derangement of the cardiac arrest. In the first picture of the patient, we can realize that the patient has a left main with no significant lesion bifurcating into LED and LCX. And we can realize here that the total occlusion is at the mid segment of the LED. Firstly, we could pass the wire into the diagonal branch, and then we modified its position later on. Now the wire is in the LED. We pre-dilated the lesion, and there was significant lesion with total occlusion as the type of the total occlusion with harboring thrombi. We stented the lesion by DES stent, and we post-dilated it by 3.25 millimeter non-compliant balloon. And this was the final result after opening the artery and making non-compliant balloon. The procedural time was 15 minutes. The patient received 100 cc contrast. 1 CBR cycle later, ROSC happened. Vasopressors were added. The patient was referred to CCU, intubated, mechanically ventilated with Glasgow scale 3, with ejection fraction of 40% with akinetic anterior septum. As the Glasgow scale of the patient was 3, we chose to put him under hypothermic protocol. 1 day later, we rewarmed the patient gradually. The patient became fully conscious. We extubated him, and unfortunately, he developed acute renal failure, for which he received 6 sessions of hemodialysis over 20 days, and he was discharged safely from the hospital. He was seen in the outpatient clinic, asymptomatic, and returned his work safely. And this was his echo during one of the visits in the outpatient clinic. We can realize that there was no regional motion abnormalities, there was no mitral regurgitation. 1 year later, he started to complain of exertional chest pain, Canadian class 2, and the decision at that time was to go for coronary angio. And fortunately, his coronary angio was okay with no significant lesion. Thank you for the whole team, the operator, scrub nurses, technicians, anesthesia team, intensivist, and Code Blue team. My take-home message is that the teamwork is the best solution to manage cardiac arrest patient. It's not one-man task show. Targeted temperature management is very helpful to improve the neurological outcome after cardiac arrest. Try to minimize your chest compression interruption as much as you can by choosing the best angiographic view. And the chance of survival after cardiac arrest is very high in patients presenting with when the initial rhythm is VF and it is witnessed arrest. And finally, never lose your hope. Thank you very much.
Terrific case. So once you regained the flow in the LAD, was the electrical instability immediately resolved? Was there hemodynamic instability? How hypotensive was the patient?
After opening the LAD artery, we resumed, once CPR cycle later, he resumed his initial rhythm, and the blood pressure was 50/30, and it was it improved markedly with the vasopressors, and we get him out of the cath lab into the CCU.
And what was the thought about mechanical support?
At that time, this is a very important question. Thank you for this elegant question. At that time, I did the echo for the patient in the CCU. The ejection fraction was 40%. He was improving rapidly. This is one point. Another point, I didn't want to make another vascular access in the patient, in this very critical patient. So I prefer to put him on vasopressors, and as he was improving, I just leave him with the vasopressors.
How long did it take him to transport the patient to your hospital, and were thrombolytics considered for this hyperacute T wave MI?
Another hospital that the patient was referred from it was about 5 minutes away by transfer, so it was less than 120 minutes, so the primary PCI was the appropriate choice. And we get him into the cath lab while preparing the patient during the cardiac arrest.
Yeah, I think the decision about mechanical support after the fact when they're stabilizing is always a little bit iffy because they are higher bleeding risk and you're wondering at that point. But I think also your pictures highlight just the complexity of trying to intervene on patients with ongoing CPR. So especially in that cohort, we typically will just put it in up front because it can really give you a better, kind of a smoother situation if you're able to maintain perfusion. At that point, you don't need ongoing CPR. That really helps you, I think, during the case, although everything went well.
Now, to be clear, though, I mean, he's in cardiac arrest, so an Impella is not exactly going to help you much, right? Because you have no RV function.
Yeah, certainly if that's the case, but I think sometimes there are patients that with the Impella support we're able to get back a perfusing rhythm, but it's obviously a mixed bag, and the eCPR is a whole nother issue that a lot of those patients are very high risk, so I don't think there's any clear-cut answer there.
So is Impella is not present in our center?
Mm-hmm.
Yeah. I would say, yeah, we had a couple of cases, and one, I think, a big save that I remember is a patient who came to the emergency room with crushing chest pain and then had VT-VF arrest in the emergency room, witnessed arrest. But whatever they were trying to do, they could not get the patient out of VF. They shocked him, they pushed epiatropine, everything. They ended up pushing lytics and still could not get a stable enough rhythm. But the CPR, and this is particularly important for the team approach, that if you are continuously doing good CPR, you are perfusing the brain well. And so they continued to do CPR for over 30 minutes. And as soon as we got a little bit of, a few minutes of stabilization, patient was brought in, he had an occluded RCA, we were able to revascularize. But the thing that also happens with these patients, and I think it's very important, once you open the artery, electrical stabilization usually does occur, but hemodynamic stabilization takes a while to happen. And these patients are not out of the woods yet. As a matter of fact, most of them, the longer they arrest, are gonna go into some sort of a shock, often vasodilatory shock down the line, and therefore renal failure, multi-organ failure. So you're at the beginning of a very prolonged recovery. So I think in this patient's hypothermia is important. I think if after the case you can provide them with mechanical support, either balloon pump or Impella these days, I think in the long run it will probably be beneficial. But obviously not every center has access to those. But don't be fooled to think that once you restore the flow, the patient is going to be just fine. You are at the beginning of a very prolonged recovery.